Hi, everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. Today, I have back with me Dr. Simmons and Dr. Sepucha, who were on our episode a few weeks ago where we did part one and we covered shared decision making as a broad topic when it comes to how patients and clinicians navigate medical decisions. Today, we're going to spend a lot of our time talking about colorectal cancer and screening and how decision making plays out in both these areas. So, Dr. Simmons, Dr. Sepucha, welcome back.
Nice to be
Thank
here.
you.
I would love to open this conversation with a broad understanding of what in the world is colorectal cancer screening. I'd love for either of you to just explain that. What are we talking about? Who should be getting screened? What are the guidelines? And we can go from there.
Sure, I'll be glad to start. So, colorectal cancer screening is a process by which patients are identified as potentially having signs of a colon cancer or a precancer, with the goal of reducing the risk of developing colorectal cancer or catching it at an earlier, potentially more treatable stage. And many guideline developing agencies issue guidelines on who should have colorectal cancer screening, when should they start it, when should they stop it, and how should they do it. But I'll summarize the guidelines from the United States Preventive Services Task Force, which were the guiding documents for the study that we conducted. So the USPSTF gives its guidelines recommendations that are graded. And grade A recommendation means that high quality evidence backs this. Strong recommendation to do as per that grade A recommendation. And in the case of colorectal cancer screening, the recommendation is an A recommendation to offer screening to people 50 to 75. There's a grade B recommendation, which is also a recommendation to proceed with this, offering colorectal cancer screening to people 45 to 49. That's a newer recommendation, and one that that is something that has been in the news a lot because there was a lowering of that recommendation. But in the case of older adults, this is where it's truly a gray area. So guidelines are clear with the USPSTF that we should not be offering colorectal cancer screening for people over age 85, because in that case, in almost all scenarios, the risks of doing colorectal cancer screening outweigh the potential benefits. That is because complications of the testing can be higher, and because patients may not live long enough to benefit from that early cancer detection. But the USPSTF advises that we do individualized decision-making for colorectal cancer screening for people 76 to 85. And the reason for that is that people in that age group have such a divergence of health status. You can be 75 and vigorous and still in your job with taking very few medications, and we expect that you're going to be living a good 20 years longer. Or you can be 75 and just out of a skilled nursing facility for an emphysema flare-up and on oxygen, someone who we actually don't expect to have very many years of life left. So this is why it makes sense to offer individualized screening options. The problem comes with, how do doctors know how to have these conversations and discuss with people the sometimes sticky issue of, you are in an age range where we don't know if you'll benefit. How do I talk about this without making you feel bummed out that we're talking about mortality, and feel positive that we have other things we can talk about with your health? So Karen and I realized there was a gap in how to train clinicians on talking about this, and also a gap in the literature on what do patients feel about this specific decision, what would be the impact of training. That is some of our impetus for the study.
Thank you for covering that. I really appreciate that. Karen, would you like to add anything to that?
In terms of the guidelines, or just in terms of our study?
Either.
So I think what, as Lee was highlighting, the areas that we really think are, perfect for shared decision-making are ones where there are real choices. So, you can have a colonoscopy, you can have a stool-based test, or you might do no screening. I think those are sort of the options that are really on the table for patients in this age group, the 76 to 85. As Lee was mentioning, there's not one right answer. It depends on their overall health status, their risk of colon cancer. Have they had polyps in the past? Have they had cleared colonoscopies? It also depends on what's most important to them. How do they feel about this? So the patient's voice is really critical in figuring out which path is best. And then I think as Lee was mentioning, some of the studies, there's not a ton of research in this area, but what research is available really does suggest that the quality of decisions is quite poor. And actually, we had one of our scientific advisors on this study had interviewed a bunch of patients in this age group, specifically asking them, what were the kind of conversations that you had with your doctor about colon cancer screening, continuing or stopping it? And what they found was that only half of the people in the room ever even mentioned that, no doctor even mentioned it to them. So you were never even given an option to continue or not continue. They never had that discussion. And so we weren't enabling patients to have a voice in that decision. So we really think this was a great opportunity to think about how do we make this more comfortable for the doctors to raise? How do we make this make patients more aware that this is actually a decision that they need to be thinking about? And it's a good time to kind of revisit whether or not we should continue or switch or stop altogether. Maybe you're done, and that would be a good thing.
I guess I have a few sort of grounding questions. So when we're talking about clinicians here, we're talking not oncologists. We're talking primary care, nurse practitioners. Is that a fair summary?
Most of these decisions are made in the primary care setting, and that could be by a physician or a nurse practitioner or a physician assistant. There are also times where a gastroenterologist will be asked to make a recommendation on this, particularly with regard to continuing screening for someone they've done colonoscopies on, but the vast majority of these decisions happen in primary care.
Got it. So we're really talking about enabling primary care clinicians to better navigate how to have these conversations for this population where the guidelines are somewhat ambiguous, and basically the guidelines say individualized decision making. So the guidelines really say that, hey, take this on a case-by-case basis, and therefore, because of that, and because I'm going to borrow something we spoke about last time, the presumed higher decisional conflict in this setting, we believe that it is ripe for an area for more research when it comes to decision making.
One of the things that we had done when we, got started, we actually talked to a bunch of patients, trying to understand their experiences and how they would feel if the doctor said, how would you feel if your doctor said you don't need a colonoscopy anymore? Of the 20 patients that we talked to, about a third said, oh my gosh, that would be fantastic. They were completely happy, if they did not have to do the prep, if they didn't have to go through that process, they would be thrilled. And you can see where this is going. A third actually were slightly mortified. Why would I possibly give something up that might help me? Why I want to keep doing this. This is really important to me. I've got maybe a family history, or maybe I feel like I'm a little bit higher risk. And then some in the middle, actually were trying to figure out, I think when they heard that there was another option, like a stool test, were happy to give up the colonoscopy, but maybe wanted to kind of keep going a little bit. And the stool test, which is, if folks don't know, it's non-invasive. You collect a sample of stool, they send it in for testing. You don't have to go into the doctor's office. You can do this at home. It seemed like a nice kind of, I guess sort of a, halfway, but you're still screening, you're still doing something, but it's not as invasive or, it doesn't take as much as the colonoscopy. So we really did see a distribution of what people would want. So that really, but you couldn't necessarily predict, so then the doctor trying to introduce this subject, they don't know if the person's going to be offended that they're telling them to stop, or offering this, or thrilled, with this, what kind of reaction are they going to get, and how do we help them raise this topic in a way that promotes a real positive conversation, as opposed to, maybe people wondering, why are they telling me to put my affairs in order, or what do they mean by this? Like, why are they possibly saying this? And that's not what we wanted to have. That was not our, intention, obviously, with this.
I feel as I'm sitting on the edge of my seat here. So how do we enable the clinician to have a conversation like that?
Well, we wanted to study that, and we wanted to know, first of all, if these conversations aren't happening, is it because doctors are simply not remembering to have the conversation or not feeling like they should have the conversation? So, as a primary care doctor, I deeply rely on my electronic health record to periodically tell me when somebody is due for their mammogram or their pneumonia vaccine. It is too hard to remember for every patient or prepare and look back and see where everything was done. I rely on some alerts. And they're really good, actually. You will notice them. You will want to act on them and resolve them if you're preparing for a patient visit. Turns out, in the vast majority of EHRs, and certainly at ours, when a patient is over 75, the routine alerts for colorectal cancer screening fall away. So this prompted conversation to have this individualized discussion is not going to be prompted unless somebody has overridden the system to make it so, or if there's a follow-up recommended after an abnormal colonoscopy, would be the usual ways. So that was one area we wanted to study and look at. Is it going to be just an issue of making sure people are prompted? But then once prompted, what can we add on top of that that might enhance the conversation and really lead to high quality conversation? So when Karen and I have done clinician training in the past, the methods that seem to work well are building a case for why this is an issue. Why would you want to learn how to do this better? What do patients seem to want? And we shared those examples of what people are saying about hearing that they may not need to have a colonoscopy anymore. What are their varied reactions? Just to make the point, not everybody's going to have the same reaction. And sharing the data behind it. Someone, just as for an example, someone who's healthy at age 76 and has never had a colorectal cancer screen, they benefit from being screened. You can add years of cancer-free life for them by offering screening in many cases. So it's worthwhile doing if that's something the patient wishes to undertake. And then getting to a realistic conversation about what it's really like in practice. So when we developed a training, we developed cases that are not easy answers for the most part. Like they're nuanced, they're difficult, they're real life. They were all drawn from real cases. They weren't from thin air. They were from our practice lives of the clinical advisors for the study, to use those to illustrate some real life things. And I also want to emphasize, and this comes up later when we evaluate the results, these weren't visits scheduled just to talk about, do I continue colorectal cancer screening or not? These visits in which we conducted the study were older patients there for annual visits or follow-up visits of chronic conditions who had a lot to talk about at the visit, not just this one issue. So any sort of training needs to understand and incorporate how to make sure this gets through, even when you have 4 med refills and new back pain and management of diabetes, and the blood pressure is really high today. And that would be an easy visit, by the way. So
I have I have so many questions for you. So I'm going to go with the first question, which is, so far we've spoken about this like age group where colorectal cancer screening is individual decision making by guidelines. The burden then sits on the clinician, the EMR, which is something that clinicians rely heavily on, not always, but very often in this population. The alert, the kind of safety net of the EMR just doesn't do its job. And because of that, we're studying it. My question for you is actually, where is the onus on the patient? Because if I'm a 75-year-old patient and I have all of these chronic conditions, by now, presumably, I've had, hopefully, some amount of colorectal cancer screening already, because the guidelines have been in place for the last decade, 2 decades of my life. So is the onus ever on the patient? I mean, I should not say it should be on the patient, but I almost want to say it should be on the patient.
So it's
Because I think
I think that's a great question. And I think, when we think about where we focus a lot of our efforts and public health communications, it is about starting screening and getting screened and keep screening. And it is hard to find, any discussion or information that, there might be a reasonable time that you stop screening. This is not about for the rest of your life. This is, if you have 3 clean colonoscopies, you're done. You are great. Like, you are fantastic. Like, your chance of getting colon cancer in the future is probably very small. You've done your job. But there's never or very little attention or public communication about that. So I think it would be hard for patients unless they were extraordinarily well-versed and looking around for looking around for decision opportunities to even know that this is an issue, because I don't think it's really communicated well. Whereas I think all of the starting screening is where most of that communication and efforts are really focused. So I do think there could be a role for, more public health campaigns. And, I know in other countries where there's more national health service, like the United Kingdom or Australia, it is very clear that, this screening is till age such and such, and then we will make another decision. So that decision is already, that's kind of built in or baked in. And we just haven't done that, certainly not in the US. We just haven't really done that.
That's a very, very insightful point, actually. I actually have never seen anything about stopping screening. That's actually incredibly insightful.
Right. Can we give them a certificate? Like, fantastic. You've finished, this is your last mammogram, or this is your last, unless you have symptoms, but, this, you're done. Fantastic. So we don't do that.
I'm down for the last mammogram. I'll just put a plug for that. I don't think I'm going to ever qualify for that, but I'm down for it. Philosophically, I'd love a last mammogram. Yeah. I'd love to go back, Dr. Simmons, to your easy appointment scenario, right? So an easy appointment is a patient showing up and they have new back pain, 4 med refills, high blood pressure, and then somehow you need to insert this somewhat tricky conversation around colorectal cancer screening. So how does that play out? And how do you coach clinicians to do that? Because it seems actually really hard, because we're talking about 12 to 18 minutes, 18 to 20 minute appointments. We're talking pretty short appointments.
Yeah. Well, there are a variety of ways that clinicians can be prompted to bring something up. Like I said, the EHR alert is a really nice one. For our study, just to be clear, we did not change the EHR alerts. We alerted the physicians shortly before the visit that the patient was due for a conversation about colorectal cancer screening. That was done in a method of the physician's preference, whether they chose a message in their electronic record or an email, and we let them choose which they wanted. And so in the study setting, that's what we did. And then it was a randomized group of primary care physicians. In this case, we only worked with physicians for this study because we wanted to work with clinicians who had a panel of patients that they followed, so they would be familiar with these patients, and these wouldn't be, cold call conversations. These would be people they've seen before. And in the intervention group, we added to that reminder also the clinician training component.
So I'm going to jump the gun a little bit, but what did the study find? What did you guys discover?
I'll let Karen start. Yeah.
So, obviously this was all about colon cancer screening. So, figuring out how did that impact screening, one of the things we were looking at was, did we do a good job of individualizing these decisions? Did we ask patients right after that visit, well, what do you want to do? Would you like to do a colonoscopy? Would you like to have a stool test? Would you like to stop screening? Are you unsure? You're not sure. And then we followed them for 12 months to see whether or not they got the stool test, or did they get that colonoscopy, or, did they not have anything? So we tried to figure out, did we do a good job of lining up patients with what they said they wanted? Yeah. And what we found was that overall, about half of the patients in our study got that concordant care. It was a little bit higher in the intervention group, like 51% in the intervention, 46% in the comparator, but it didn't meet the threshold for statistical significance. So we didn't find a difference there. I think the big caveat, which we might come to later, is we launched this about 4 months before COVID shut down the world. So the reason they didn't get a test or that they might have wanted could have to do, and we do have some evidence that was an impact in terms of them being able to actually follow through with the colonoscopy. So that was one of the things we were looking at. And then the other main outcome was this idea of, did that conversation happen? And then did we increase shared decision-making in that conversation?
Yeah. And so when we looked at what the conversations were like, and this was drawn from what patients were saying they experienced during the visit, surveyed shortly after, we calculated something called the shared decision-making process score, which looked at, did you even talk with your doctor about no further testing? Okay. Did you talk about the reasons to screen, to do a screening test? Did you talk about the reasons not to screen? And were you asked about your preferences? And we found through that the patients who were in the intervention arm, where their doctors had been given extra training, not just the reminder, but extra training on shared decision-making around colorectal cancer screening, they actually did have more, they had more conversations about colorectal cancer screening. They were asked more often about their preference. And their total shared decision-making process scores were higher with statistical significance, but with the caveat that they were still low. These elements of a high-quality conversation with patient involvement and just detailed discussion about the pros and cons of screening were still happening at a relatively low rate. And that may have been in part because these were, as I said, not a visit booked just to talk about this, but rather in the context of real primary care, where maybe you didn't just talk about colorectal cancer screening, but also about the prostate cancer screening that was continuing, or the mammogram that your patient is still getting in her early 80s, and do you want to continue or stop? So this may not have even been the only cancer screening discussion happening that day. But when we looked at those elements, it did seem that training prompted more discussion about preferences and more discussion about the options, other options for testing. So more discussion about stool-based testing if your doctor had done the intervention. Your doctor was in the intervention group and had done the clinician training.
So doctor, if I'm a patient listening to this episode, and if they had to take away one thing from this episode, what might that be?
What I would say here is that we also found that when we asked patients how much time was spent on the conversation about colorectal cancer screening, the ones that spent had a little more time spent, and we were giving, this was all self-report afterward, okay? But the ones who said that 2 to 5 minutes or more than 5 minutes were used, as opposed to less than 2 minutes, it only seemed to take getting to a 2 to 5 minute conversation to talk more about options and to be asked about one's preferences more. So I would say that this discussion is an important one. It shouldn't take a lot of time, but you're going to need to be involved in the conversation with your doctor when you face a colorectal cancer screening decision for someone 76 to 85. And I think this has broader implications, because if you're listening, you may have a parent who's in this age range, and you may be wondering, why is my mother still getting colonoscopies? Or why is my mother not being offered a colonoscopy? Were her colonoscopies normal before? I don't know. Maybe I should ask her to ask her doctor, because all of those elements actually factored in to these conversations. What has been your colorectal cancer screening history? Are you following up on polyps? It turned out that half of our patients had prior polyps on colonoscopy, and that's a normal finding for this age sample. So that's not unusual at all. So these conversations were complex without a strong evidence base for what exactly we should be doing in terms of surveillance of polyps for people who are older. So I would say, listening to this, realize that this is a shared decision. There is not a guideline that fits one size fits all. And you should be taking those couple of minutes to talk with your doctor about this important decision.
Thank you so much. Karen, anything to add to that?
Yeah, I think this is probably more for the U.S. population, because I think in the U.S. colonoscopy really is, as Lee was mentioning earlier, kind of considered the gold standard. So I think even just understanding that there are options, there is a stool-based test option. And what we found, surprisingly, in our study was that we actually increased screening rates. We thought we were going to decrease by giving them options, but we increased screening rates. But that increase was due to more people doing stool testing. So I think people had never heard of this as an option, and were certainly interested in something that seemed, very low complication rate, low risk, but able that they could keep doing something. So knowing that that's an option, and maybe talking to the doctor, raising that to the doctor as, would it be better for me to maybe switch to a stool test? I think would be, something to take away, if that's something that they're interested in, avoiding the colonoscopy, and but still, maybe monitoring in some way their colon cancer. So.
Samira, Karen's making me think, there's no sweeter music to my ears than a patient saying, do I have options? Are there options? I mean, you may need to prompt your doctor too, because it's so nice to hear that somebody would be open to another plan or some discussion. So I think that's a useful phrase. Are there alternatives? Do I have options?
Do I still need to take this test?
Yeah. Yeah, maybe. But there will be times too that that the doctor may feel really strongly that clinically it really is important, and maybe between the two of you, or family members too, you can come up with a plan that still gets the patient the treatment that they should have, but is addressing their concerns. As Karen mentioned, some patients chose to switch to stool testing, which may not be right in all circumstances, but may be exactly the right method for the patient at that time.
I would actually love to talk a little bit more about the question, do I have options? Because, Dr. Simmons, I can tell you that given the work we do now, we talk to a lot of cancer patients. And this is people who are not getting screened for colorectal cancer. This is like, you have a diagnosis, or you're getting diagnosed.
You have a diagnosis, yeah.
You're in the middle of treatment, or you're in survivorship, or you're living with cancer long term, or you may be in like hospice settings. Like we know our community is full of people kind of all over the experience journey on the side. And I can tell you that question is sometimes very hard, because sometimes before you even ask that question, the answer is probably a no, or you're choosing between terrible things and really terrible things. And the reason I bring that up is I personally, this is again one of like my personal opinion here, which is I'm a huge believer in that question. I think it shows up in pretty much every single appointment of mine for any doctor at any point. For anything that we're talking about, because I realized fairly early into the cancer experience was because we are so guideline driven in early stage breast cancer that it becomes hard to personalize care because we're so guideline driven. And the only way to really question the guideline is to ask the question of like, do we have options? And it's that question that kind of triggers the like, okay, we have to think about it. right? It's that moment of like, okay, let's take a step back and talk about it and think about it.
Hmm.
So I personally have definitely seen that question be one of the questions I carry with me to any medical appointment. But I also know that it's sometimes really hard. It's sometimes so hard to ask that question because sometimes you just know you can just look at the doctor's face and you know the answer. And
Well, I can certainly see in how in many settings that could be really difficult. And I'm going to rephrase the way I would ask it, which is open ended, because I agree with you. I think the either the fear of a no response or the actual no response could happen. Maybe let's talk. Could we talk about my options? Could we talk about some options? You're not going to get a no to that, I don't think, in most circumstances. But it is an invitation on from the patient side of a broader conversation. That's just one early thought.
I
I think
love
another
that.
thought, in terms of how to do this, especially in sort of those difficult situations, and there's, in decision science, there's sort of two camps. There's the option camp, start with what you can do, and then there's the
Mm,
value camp, which is start with what you want.
Huh.
And so it may be that the conversation is, here are my goals, and maybe it's, at some point, maybe it's not as live as long as possible anymore, but I want to keep living independently, or I want to be able to keep driving, or I want to be able to go on this trip.
Yeah.
How can you help me get there? Like, how can we get there? So maybe it's, sometimes starting with the
yeah,
goals
I like that.
and then eliciting the clinician to help think about, okay, how do I help you get there? And then when we get there, then we can get on the next goal. And, so that might be another option, which is kind of flipping the script,
Hmm.
so that, they're really, thinking about ways to help you achieve what's most important to you.
I love both those answers so much. I need to summarize this because I think those two insights are so profound that I definitely want to underscore it. So the first is reframing the question, right? So it's still exploring optionality, but instead of framing it in somewhat of a binary fashion of a yes, no, maybe we make it open ended. Something like, could we talk about options or could we talk about my options? But then Karen's suggestion is you may just want to reframe the script entirely. Is to start with the goals, start with values. Like, what is it from your life's perspective that you want to have happen in the near term, long term?
Hmm.
And then make it a goal oriented discussion, which is that's the goal. How do we get there?
Hmm.
As opposed to an option oriented question. So
Yeah.
I love both of those. Those are great suggestions. I love that. Okay. Um, I'm going to bring us to a close of part two with a question to both of you. And the question is, let's say you have a magic wand and you could change anything in the doctor patient interaction and you could change it today magically. What would you change? And it can't be like we remove colon cancer and it cannot be the let's not have any more cancer in the world. That is not an option.
But it is a magic wand, right?
It is a magic wand with limitations.
So I know my magic wand. I don't know. Maybe I'll start. So it reminds me of my kids love the Harry Potter series, and in one of the Harry Potter series, Hermione has this like time traveler, so she can go and take all these courses and never runs out of time during the day. And so I would love to give our physicians a time traveler so that they could take whatever time is needed to address the issues for that patient, but still get home at 5 o'clock and eat, still have a life outside of their medicine, but be able to really spend the time with each patient to have these conversations and not feel that pressure.
Oh, such a good answer.
Yes, Karen's answer is great. I'm going to add to that and say that I would reframe how we think about decision making with patients completely, in that it's a process. I'm speaking more from the primary care perspective. I recognize that there are things in oncology that might be a little bit different, but a lot of it I think would apply. Whereas where nobody is expecting that decisions are going to be made in that moment, and that we're redesigning how we think about significant medical consultations, where someone is reached out to early with high quality information that makes sense for their condition, tailored to them to the extent possible. They have their consultation, and then there's a planned follow-up to check in about where they are in the decision, that we're not rushing things that don't need to be rushed, and we're giving things the time that they need. And we are cutting out the extra stuff that maybe doesn't need to happen in that visit, and completely focusing on what matters the most. And that's the way I would magic wand the situation. These medical consultations are significant. They can change the rest of someone's life. And we want to get that procedure right.
Can I just say I want to live in your world so badly. I definitely want to live in that world, because I think what you just said, I really, really wish that we could make decisions that way. Like, I can't think of any other part of our lives where we are making effectively somewhat, not always, but somewhat an irreversible decision.
Sometimes.
And
many times.
And you're doing it in 15 minutes. It's like you're making an irreversible decision. Not always, and there are easier decisions, but it's a pressure cooker. And you get into these like pressure cooker moments, and all of a sudden, I just know that like my brain doesn't work as well. It's just my brain's not working as well, because I know it's tight, and you have to make this call in that window. So your answer of like, let's just expand the window, let's change the flow, let's get you patient prepared, let's give you the consult, let's give you time to think about it, and then follow up, is I think it's such a elegant solution to the problems we face. So thank you for sharing that. And I absolutely think every clinician should get a time turner from Harry Potter. Of course, that's just a given. So with that, I want to thank both of you for joining us and for sharing your insights, your wisdom, your theories, your frameworks. I can tell you, I know that people listening in are going to walk away feeling like they have new questions to ask, new ways to think about medical decision making. So I really appreciate you both taking the time and sharing that with us. Thank you for joining us. This episode was supported by an award from the Patient-Centered Outcomes Research Institute. This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions.